Yeah, that's good. Is it, do you guys keep it internally or do you make that publicly available?
We can disseminate it, yeah, as a Zoom link. It's just the file's pretty large, so I'm trying to figure out an easy way to do that because
Yeah,
the through like email, it's pretty tough.
yeah, no, the reason why is I don't know if I have like a formal YouTube channel. I keep getting these stuff that people apply to my YouTube channel, but if it is publicly available, it's, for me, it's always nice to kind of put it on the put it on YouTube or something like
For
that.
sure.
It's amazing. I just got back from Africa, and I'm teaching at a university there, and one of the fellows that I've been working with has been watching these YouTube videos for the last 5 years, and I was like, "You got to be kidding me!" But it's amazing what type of legs these things have. So, I mean,
Amazing.
if you discuss it internally, and then people are okay with it, I know there are lots of hoops to jump through, but I think it would be a nice little contribution.
Yeah, for sure. We can work on that. I'll try to figure out how I can send that to you as a link, whether we have like a Dropbox or something.
Okay, or even just the video. So Gmail works pretty well for me. If Gmail is pretty good. Then if I can
Sounds good.
download, then I can upload it myself too. So
Perfect. We can make it work.
great. All right. Okay, so shall we start?
Yeah, please.
Okay, great. Well, yes, apologies for the communication gap. It's probably on me. I'm getting older and I'm losing brain cells. But what I'm going to do is for the next 15 minutes or so, we're going to talk about a simplified approach to the spaces of the head and neck. And, we're really going to keep this, super simple. I'm not going to muddy the water on this. There was a famous, oh gosh, the phone's ringing the bell. There was a famous anatomist by the name of Malgagny who wrote the names of the spatial spaces changed by the author, and that was written in 1813. So the point is that anytime that we talk about the spaces and the fascia and things like that, they've changed over time. In fact, I think since I was a fellow, I think some of these spaces have changed their names about 3 times already. Um, so I'm going to stick with the terminology that I use, knowing full well that there are other names for it. But what I really want to do is to emphasize the concepts of this, because if you understand the concepts, then everything is going to be easier. So the first space that we'll talk about is the masticator space. So pure and simply, the masticator space are the muscles of mastication. So so much about head and neck, it's really about anatomy. If you don't understand the anatomy, you can spend all the time you want to on YouTube videos and reading books. It's just not going to be there. In fact, my son's a first year medical student now, actually a second year now, and my gosh, when I was in medical school, we spent, about maybe a year on anatomy. Now it's, even less than that. Now they pick it up obviously as time goes on, but when it comes to really head and neck anatomy, we didn't get it much when I was, younger. Now it's people really, you really go through it fast. So number one, the point is when we talk about the spaces, and what I'm going to do is give you an anatomically based approach. So we have to remember what is the masticator space? Well, the masticator space is comprised of the muscles of mastication. So what are the muscles of mastication? Whereas there's this big muscle right here, which is the temporalis muscle. Then we have this muscle right here, which is a masseter muscle. Then we have this muscle right here, which is the lateral pterygoid muscle, and this muscle down here, which is the medial pterygoid muscle. So honestly, the lateral and the medial for me were misnamed. This really should be superior pterygoid muscle and inferior pterygoid muscle. And again, that sort of gets to the confusion. But the point being is that when we look at the masticator space, it starts all the way up here, involving the temporalis muscle, then comes all the way down here to the base of the masseter muscle. Now, when we look at the masseter muscle, we also have the second component of the masticator space, which is bone. So the bone here is predominantly comprised of the mandible. So anytime that you see bone, that's part of the masticator space. So in this particular case, we can see the coronoid process, and we can see the condyle of the mandible. In this case, we can see the body and the ramus of the mandible as well, too. Now, the third component of the masticator space is this little nerve right here. So there's a little nerve right here that is a third division of the fifth cranial nerve. So the three primary components of the masticator space are muscle, their bone, and there's nerve. So the reason why I mentioned this is that when we start talking about masses involving the masticator space, we need to take an anatomically based differential diagnosis. So we know the largest component of the masticator space is muscle, then followed by bones, and then followed by nerves. So if we were dealing with a child, a 13-year-old child, and we say there's a large mass involving the masticator space, then the most likely mass is going to be rhabdomyosarcoma because muscle is the largest component of the masticator space. Then the second thing are going to be these various bone lesions. And so from a radiologist standpoint, I know, we tend to get heart palpations and things like that when we talk about head and neck, but realize the bone is ubiquitous. It's anywhere in the body. So when we talk about differential diagnosis for bones, the most common things that we'll run into are osteomyelitis, we'll run into metastases, we'll run into myeloma. And then you do have to worry about some of what I refer to as the crazy jaw lesions, like odontogenic keratocysts, dentigerous cyst, ameloblastomas, so on and so forth. So that's the second component. And the third component is the nerve. So remember, the two of the common tumors that involve the nerves are schwannoma and neurofibroma. And then especially when we're dealing with the head neck, we can have perineural spread of tumor. So again, I emphasize this first space because it's important to understand that concept. So muscles of mastication, bone, and nerve comprise the three components of the masticator space. So here's an example of a mass involving the masticator space. So one of the challenges that we run into is how do we know that this is in the masticator space? So number one, what I do, and it's pure and simply, I see this large mass here, we can obviously see it, and I place my arrow right in the middle of it. And then I draw a line down the middle and I go to the opposite side and I see, wow, this thing is arising from the masticator space. Now, if you look real closely, we'll discuss this space later. Notice how this lesion is not arising in this little fatty space. This is the space next to the pharynx. It's the parapharyngeal space. We'll come back to that. And notice how it is not arising from this space back here, which is the parotid space. It's pushing the parotid space, but it's not arising from it. And that helps them from a differential diagnosis standpoint, because this was a sarcoma that was arising from the masticator space. If you incorrectly isolated this, and I've seen this done before, then you would think that it's a parotid space mass, so then you'd be thinking about pleomorphic adenomas, Warthin's tumors, so on and so forth. In fact, a little funny story right here. One of the people I worked with years ago, a non-radiologist, and insisted a similar mass was arising from the parotid gland, and we biopsied, and it turned out to be a leiomyosarcoma. And he wanted to write it up as a case report, meaning a leiomyosarcoma arising from the parotid gland. And I just said, you can write it up, but just don't put my name on it, okay? Because it was actually arising from the masticator space. So that just underscores the importance of identifying the proper space. Here's another example. This was a 17-year-old that presented with a mass involving the masticator space. Again, notice how it's deep to the parotid gland here, and it's involving the pterygoid musculature. And this happened to be a rhabdomyosarcoma arising from the masticator space. Again, the most common, largest component is the muscles of mastication. Now, this is that second component of the masticator space. So these are these lesions. In this case, this is a large osteoma that arose from the condyle of the mandible. It is a masticator space mass. And this was an expansile lesion arising from the body of the mandible. And this expansile lesion turned out to be an ameloblastoma. So again, this is that second component. We talked about the muscle, then we'll talk about the nerve. And then that third component is going to be V3. So V3 is located just medial to the lateral pterygoid muscle. And here we see this mass right here. There's a round mass right here. Notice how it's just medial to the lateral pterygoid muscle. In fact, it maps out very nicely to where we would see V3. In fact, this was retrograde perineural spread of tumor along V3. And if you've really got a good eye, if you compare the left masticator space to the right masticator space, notice how we're starting to get some fat and some edema. And this was actually denervation atrophy involving the muscles of right mastication. So this was an example here of perineural spread. And one last example here, this was an oldie but goodie because I think it just nicely demonstrates the anatomy. Here's a lateral pterygoid muscle here. This oval-shaped structure right here is V3. You have this large mass right here, and you're like, where's this mass arising from? But if you look real closely, you can see that lateral pterygoid muscle is displaced laterally, and this mass right here is medial to the border of the lateral pterygoid muscle. That places, again, right where we'd expect to see V3, and on the coronal images, we can see this mass growing superiorly through foramen ovale into the region of Meckel's cave. So this, in fact, was an example of a schwannoma involving V3. So the next space that we'll talk about is something that you all are all pretty familiar with, and this is what we refer to as the visceral space. Now, the visceral space has different names to it. Some people call this the pharyngomucosal space. The reason why I've always called it the visceral space is that this was the name given in the classic 1939 article by Grudinsky and Holyoake, so I always tend to use that name. But on the other hand, if you'd rather say that this is a space that involves the mucosa of the pharynx, pharyngomucosal space, it's completely fine to say that. Now, when we look at this fascial layer right here, there's a fascial layer right here, this little black arrow. That fascia has, again, two names to it. If you're going to call this the visceral space, well, I just call this the visceral fascia. If you're going to call this the pharyngomucosal space, you can call this the pharyngomucosal fascia. But as you get closer to the nasopharynx and the skull base, it becomes very, very thick. And then it becomes a pharyngobasilar fascia because it attaches basically the pharynx to the skull base, hence pharyngobasilar fascia. So you all know this very well because anytime that you perform an endoscopy, what you see here lining the the mucosa is going to be within the visceral space. So for my radiology colleagues, basically if you look in someone's mouth, everything that you see is going to be in the visceral space. So this is an example of a visceral space mass, and we're at the level of the nasopharynx. And this, in fact, is nasopharyngeal carcinoma, squamous cell carcinoma of the nasopharynx. And from an ENT surgeon standpoint, I know that this is going to be on your boards. Anytime that you have an adult presenting with unilateral serous otitis media, so this is mucosal thickening involving the mastoid air cells. If you look real closely here, you can see the basal turn of the cochlea. And here we see fluid in the middle ear extending anteriorly through the opening of the eustachian tube along the eustachian tube. So anytime that you see this, then your eye next time has to go to the fossa of Rosenmuller and the nasopharynx to make sure that this obstruction of the eustachian tube, this eustachian tube dysfunction, is not due to a tumor involving the nasopharynx. Now, this is an example of an unusual case, and it makes a very important point, especially for our radiology colleagues, because everything that we can see, or I should say, the majority of lesions that involve the visceral space are going to be visible at endoscopy. So here we see this polypoid soft tissue mass right here that's involving the nasopharynx. And in fact, this turned out to be metastatic adenocarcinoma involving the nasopharynx. So there's no way that you can detect that based on imaging, but it does make that important point that anytime that I see a mass right here, I always want to correlate it with endoscopy. And as you guys know, I see patients on Wednesdays. In fact, we had our clinic today. This is where I just came from. So, I'm become very familiar with the importance of endoscopy, but also importance of saying, hey, if I see a big polypoid mass in the visceral space, my job is not necessarily to give a big differential diagnosis, but it really is to talk about the deep types of spread. Now, here's an example of something that can be a bit confusing. We have a child here that's presenting with this abnormality involving the nasopharynx. So when we look at the nasopharynx, we can see this large enhancing mass. And if you look real closely, we can see some striations. They almost look like little tiger stripes right here. And if we look real closely, we actually see retropharyngeal lymph nodes. So if this was a 70-year-old male or something like that, then I would say, my gosh, this really looks like either lymphoma or squamous cell carcinoma. Now, kids, and this was a kid, can get squamous cell and they can get nasopharyngeal cancer, but most commonly, this is due to adenoidal hypertrophy in the nasopharynx. And remember, in kids, they oftentimes get enlarged lymph nodes. There's no real size criteria for lymph nodes in kids. So this is just an example of advanced nasopharyngeal adenoidal hypertrophy, giving us this large mass involving the nasopharynx. And here's the classical example of a submucosal mass. So in this particular case, we can give a differential diagnosis because if you perform your NP scope, you're just going to see this little subtle bulge involved in the nasopharynx. And this is a non-contrast T1 weighted image, and this happens to be a little torn wall cyst right here that's located within the pharyngeal bursa. So the next space that we'll talk about is the space behind the pharynx. So pure and simply, what do you call the space that's located behind the pharynx? Well, that space that's located behind the pharynx is the retropharyngeal space. Now, this fascial layer, like I said before, I'm going to be consistent in my terminology. I'm going to call this the visceral fascia. And if you look real closely, there's a dashed line right here. Now, this dashed line right here is going to be the alar fascia. So the space that's located between the visceral fascia and the alar fascia is the true retropharyngeal space. And this true retropharyngeal space contains the lateral and the medial retropharyngeal lymph nodes. Now, the space that's located between the alar fascia and this fascial layer right here, this dotted line, is going to be the danger space. So the danger space is located between the alar fascia and this dotted line fascia. And again, it has different names to it. You can either call it the pre-vertebral space or the perivertebral space. Either one of those names is fine. So retropharyngeal space and the true danger space, and that separation is from the alar fascia. And this is an example of a patient that had penetrating trauma demonstrating air within the retropharyngeal space. Now, based on this, I can't say whether it's in the danger space or the retropharyngeal space. I just don't know. But what you can occasionally see is this midline raphe. So sometimes you will see this little midline raphe in the retropharyngeal space. So some practical things that you may run into, and this was a case years ago that was a child and the surgeon wanted to do a tonsillectomy and he looked in the throat and he saw a pulsating mass. This, in fact, was a markedly ectatic left internal carotid artery. So this is the classic retropharyngeal carotid artery. And now in the days of TORS, if you are contemplating doing transoral robotic surgery to resect oropharynx cancers, you really have to make sure that you properly identify the course of the internal carotid artery. So, it's not sort of a radiological uniqueness. It really is important when you are trying to contemplate sometimes TORS versus non-TORS. Now, here's an example of a patient that had a squamous cell carcinoma involving the oropharynx. Now, remember, you have these lymph nodes back here that we talked about. So we talked about the lateral and the medial groove. Now, this was a metastatic lymph node to the retropharyngeal lymph nodes. And I always say that this is our lymph nodes. And the reason why I say that is that if you looked and you performed an endoscopy right at the level of the soft palate, you may see a little bulge, but probably not a lot. And you're not going to be able to palpate this on physical exam. So I always say that from a radiologist standpoint, this is our lymph nodes, because these are the lymph nodes that we can detect. So I think you said there are some McLaren radiologists on the line. Hello, how are you? Great to meet you. From a positive retropharyngeal lymph nodes, these lymph nodes are not resected into standard neck dissection. And it's also going to depend on how this influences treatment. If this patient was still contemplating surgery, then some surgeons could go in and go ahead and do an incision and maybe resect this using their finger. I've heard of that. But on the other hand, there's other surgeons that would say, hey, if I see this metastatic retropharyngeal lymph node, then I think these patients are better treated with radiation and chemotherapy. So that's why these lymph nodes are really important from not only a staging standpoint, but from a treatment standpoint, because they're not included in the standard neck dissection. Now, this is an example of an entity which is oftentimes confused. So what we see here is a child that presents with a sore throat and presents with a fever and has a hot tonsil. So this patient has a pharyngeal infection. Now, when you look at this, you see this fluid collection that is not midline, but it's paramidline. And if you see this paramidline collection, this actually corresponds to this lymph node. Now, this is not a true abscess. The terminology for this is actually suppurative adenitis. It's suppuration of a lymph node. And the reason why it's important to note, and again, I hate to say this, but I trained in the last century. When we first started becoming familiar with this, what would happen is that the surgeons would take these kids to the operating room, they would drain this, and they would get maybe 1 or 1.5 cc's. And oftentimes when they open the neck, they'd sort of see this dish watery fluid, more edema. And actually, this was just suppurative adenitis. And so after a while, at least the surgeons I worked with say, if we see this, we don't want to operate. And now these patients can be treated with broad spectrum antibiotics as long as the airway is stable. So if you see this type of paramidline fluid collection that corresponds to the lateral retropharyngeal lymph node, then the proper terminology is suppurative adenitis, and these can be appropriately treated with broad spectrum IV antibiotics as long as the airway is stable. But on the other hand, if you see this, notice how you see this large fluid collection that conforms to the retropharyngeal space. Now, this is a true retropharyngeal space abscess. In fact, literally a week ago, we had a similar case, and the patient went directly to the OR, and it demonstrated this similar finding that I'm about to show you. And that is that the retropharyngeal space and the danger space act as highways that extend from the skull base through the mediastinum. So in this diagram, the purple line right here corresponds to the true retropharyngeal space. And the inferior portion of the retropharyngeal space terminates somewhere between T2 and T6. But on the other hand, the orange line right here, this orange corresponds to the danger space. And the danger space extends all the way through the mediastinum and goes through the curve of the diaphragm and is contiguous with the retroperitoneum. So anytime that you have an abscess that's involving the region of the retropharyngeal space, you must extend your imaging to look in the mediastinum. In this case, this patient had a large mediastinal abscess. And like I said, I mentioned before, I have a case, I just haven't had a chance to update it yet, with a very similar appearance that has a very large abscess in the posterior mediastinum just last week. So, this is more than just radiological curiosity. These are real world conditions. And it actually makes a difference because, from a surgical standpoint, the surgeons did a really great job draining the retropharyngeal abscess. But the challenge was that once we got down below the clavicle and you had the mediastinal abscess, that was something that needed to be managed by the cardiothoracic surgeons or the cardiac or the thoracic surgeons. And it can be really challenging to get these pus pockets. So just be aware that this could potentially be an area of residual or recurrent abscesses if you do have an extensive head and neck infection. Well, the next space that we'll talk about is the pre-vertebral space. Now, again, this changes names. Again, I use the old terminology, if you will. This dotted line right here is the pre-vertebral fascia. It's also now known as the perivertebral fascia because it extends laterally and can also encase some of the paraspinal muscular. So it doesn't matter whether you say prevertebral or perivertebral, and I've also heard it called paravertebral. So, you can choose whatever you want to call it. You can say tomato or tomato, it doesn't matter. But for me, what's most important is that you understand that there is a fascial layer right here, which encompasses these deep neck spaces. Now, the interesting thing is that when I give these talks to my radiology colleagues and I say, have you ever seen the prevertebral space or the paravertebral space or the perivertebral space? Everyone oftentimes gets a blank look and they'll say, no, I've never seen it before. But the funny thing is that if you're a radiology resident or a staff, you see this every single day. And in fact, it's probably the next space that you see most commonly, because anytime that you're looking at a spine MRI, basically you're looking at the prevertebral space. because when we talk about the anatomic components of the prevertebral space, the majority of them are going to be the vertebral bodies and the disc spaces and these muscles here, which are the longest coli muscles. So the most common pathology that we'll see in the prevertebral space is actually going to be this. It's going to be discitis and osteomyelitis. And this was a patient that ended up having extension of a discitis and osteomyelitis into the retropharyngeal space as a retropharyngeal space abscess, and then also an epidural abscess. So this is all a prevertebral space abnormality. And this is an example of the classic prevertebral infection. We don't see this very often in the US, but I just came back, as I mentioned, from Africa, and you do see lots of cases of tuberculosis. In this case, it's what we refer to as Pott's disease. So the point is that the most common pathology in the prevertebral space is going to be that typical pathology that you see in the spine. Now, when we do talk about the head and neck, the spine has two polar areas. There's one at the top and one at the bottom. And the area at the top of the spine is referred to as the clivus. And there is this unique disease entity that can either rise at the top of the spine or the bottom of the spine. And this is the classical appearance of a chordoma. So if you look at the sagittal T2 weighted images, well, when you first look at it, you can say, wow, this abnormality is kind of eroding the spine right here. And lo and behold, the T2 signal is actually similar to what we see in the CSF. It's similar to what we see in the fourth ventricle. And it's actually similar to what we see in the spinal fluid. But on the other hand, so you think, well, could this be a large encephalocele or a pseudomeningocele or so on and so forth? But when we give contrast, we see that this mass is actually enhancing. So this is, if you will, it's sometimes referred to as the pseudocystic appearance of this mass that arises from the polar area of the spine in the clivus. And this is the classical appearance of a chordoma. And the reason why chordomas have this pseudocystic appearance is that they contain these special cells that are called fossiliferous cells that contain mucin and glycogen. And this is why you have this increased T2 signal giving you that pseudocystic appearance. So you don't want to confuse this. Always look at your T1s pre and post, and this will confirm that you're likely dealing with a chordoma. Here's some other examples of lesions that can involve the prevertebral space. And again, I don't want you worry too much about the pathology. It's just realizing that it's involving the prevertebral space. So remember, the prevertebral space is comprised of the muscles and the bone. So this is an example of an aggressive lesion involving the clivus that's actually encasing the carotid artery and extending back into the posterior fossa. So this was a large neurofibroma that was involving the skull base. And the key thing here is just realize that this involvement of the vertebral body puts in the prevertebral space. Now, here's an example of a patient that presents with neck pain and also presents with difficulty swallowing. And, when we think about neck pain and difficulty swallowing, lots of things go in our mind. But in this particular case, we can see this calcification right here that's conforming to the longest coli muscles. And this, in fact, is longest tendon colonitis, calcific tendinitis. Again, lots of names to it. We'll just call it calcific tendinitis. Other people will call it CPPD of the arthropathy because it can involve the spine as well, too. But occasionally, it can give you this very robust inflammatory response. So if you do have patients that present with neck pain, remember to look for this CPPD arthropathy or this calcification involving the tendon. And this is very nicely treated very easily with anti-inflammatory drugs. Now, here's a patient that has a prevertebral space mass, and this patient presented with trauma. So again, we talked about the components of the prevertebral space. We talked about the spine, the vertebral body. We talked about the longest coli muscles. We talk about the discs. We talk about the paraspinal musculature, but we always have to remember the vessels. So we have these vessels right here. So here's one vertebral artery on the right, and here's one vertebral artery on the left. And notice the lumen of the vertebral artery is smaller on the left. And the reason is this patient, after trauma, presented with neck pain. as this patient has a vertebral artery dissection. So remember, when we are dealing with prevertebral space lesions, we want to think of the spine and the bone, but remember, we have these little vessels right here in the prevertebral space as well. So the next space that we'll talk about is relatively straightforward, and that space is the parotid space. So what lives in the parotid space? Well, it's the parotid gland. So when we look at the parotid gland is a triangular shaped gland, as we all know, and there's a little vein that runs right in here, and that's the retromandibular vein. The reason it's a retromandibular vein because it's behind the mandible. Now, the retromandibular vein is an excellent marker for the nerve that's associated with the parotid gland, and that nerve is the facial nerve. So this diagram right here, you guys probably know I love looking at old articles. And this article, believe it or not, was, anybody know where this article came from? Someone can put in the chat where they think this article came from. Next time I'll see you, I will buy you I'll buy you a Diet Coke or a adult beverage or something like that if you want. But I don't see any put in the chat yet, but that's okay. Let's see, anybody in the chat? Nope, not yet. This was actually from Charles Bell's article. So Charles Bell, you probably know Bell from Bell's palsy. So this was the article, this was the diagram that Bell wrote in his article on facial nerve palsy that he wrote in 1821. And I've always fascinated by this because, you know, in the days of computer graphics and so on and so forth, this is just an incredible diagram, not only looking at the facial nerve, but if you look real closely, we can see V1 as it exits the supraorbital foramen. We can see V2 as it exits the infraorbital foramen. And lo and behold, we can see V3 as it exits the mental foramen. So the main thing that we'll talk about here is the facial nerve. So the retromandibular vein is an excellent identifier for the facial nerve. So the nerve is going to be just lateral to the retromandibular vein. So the facial nerve, as we can see in this lovely anatomic illustration from my friends in Argentina, have a fan-shaped appearance, and it separates the parotid gland into a superficial lobe and a deep lobe. So here's our superficial lobe, and here's our deep lobe of the parotid gland. So once the facial nerve exits, it exits this foramen right here, which is between the styloid process and the mastoid bone. It's a stylomastoid foramen. I'll show that in just a second. This is the main trunk of the facial nerve, and then it has these 5 branches here. Now, I always forget the branches, but I just got back from Africa, and I actually went to Zanzibar. So Zanzibar, you know, it was a great trip, obviously, but there is a mnemonic, believe it or not, that can help you identify the branches of the facial nerve. And the branches, the mnemonic is to Zanzibar by motor car. So remember that one, to Zanzibar by motor car. So the T is two is the temporal branch, temporalis branch, temporal branch of the facial nerve. The Z is going to be the zygomatic branch. The B is going to be the buccal branch. The M is going to be the mandibular branch, and then the C is going to be the cervical branch. So we have 2 Zanzibar bimotor cars. So those are the 5 branches of that facial nerve. So when we look at the parotid gland, some of the things that we can see in the parotid gland, here are some classical examples of lesions involving the tail of the parotid gland. So if I told you that this patient did not have a history of lymphoma or melanoma or anything like that, and we see these lesions, the most likely diagnosis is going to be a Warthin's tumors. Now, Warthin's tumors have a tendency to be bilateral and multiple, and they tend to involve the tail of the parotid gland. Now, why is that the case? The reason is that the other name for Warthin's tumors is cystadenoma lymphomatosum, which means that it arises from lymphoid tissues within the parotid glands. Now, the parotid gland actually has 4 sets of lymph nodes. They're located in the pretracheal area. They're located below the capsule of the parotid gland. They're located along the facial nerve, and they're located in the tail. And because Warthin's tumors arise in these lymphoid tissues, that's why Warthin's tumors tend to be multiple and bilateral and tend to involve the tail of the parotid gland. Now, here's another example. This patient has multiple cysts involving the parotid gland. And back when I grew up, when I was a resident, we would show this and we would get it automatically because this was a patient that was HIV positive. I did my residency during the AIDS epidemic in the 1990s, and it was very common to see these lymphoepithelial cysts involving the parotid glands. Again, we don't see this as often as we used to, but occasionally you will run into these multiple lymphoepithelial cysts. Now, from an imaging standpoint, why is it important to identify where the facial nerve is located? So here's the facial nerve right here. This is the retromandibular vein. It's important because it'll help you determine whether you should do a superficial parotidectomy or a total parotidectomy. In this case, we see this little mass right here, a well-defined mass. This turned out to be a very small pleomorphic adenoma, but notice how it's superficial to the facial vein, or excuse me, the retromandibular vein and the facial nerve. So this can be appropriately treated with a superficial parotidectomy, and here we can see the nice branches of the facial nerve. But in this case, we have a mass right here that's involving the deep lobe of the parotid gland and extending into this parapharyngeal space. Here's our retromandibular vein, and then notice how the facial vein is going to be here. So this is involving the deep lobe of the parotid gland. So in this case, you would have to do a total parotidectomy. So for my radiologist colleagues out there, our surgeons can oftentimes feel a parotid mass, but they don't know is what that deep extent is. So that's why it's important not only to give a differential diagnosis, but also in the context of this lecture is to identify whether it's in the superficial or the deep lobe, because that specifically directs how the type of surgery that will be performed. Now, here's an example of a patient that has a mass involving the right parotid gland. So here's the styloid process here. Here's the mastoid air cells right here. And if you look real closely, we can see this mass right here involving the right parotid gland. Now, this mass is extending deeply between the styloid process and the mastoid air cells. And we can see that the gray stuff here, this is all tumor extending into the stylomastoid foramen. Now, the stylomastoid foramen is where the facial nerve exits. And in this particular case, this is retrograde perineural spread of tumor. So this tumor extended into the stylomastoid foramen. It's growing superiorly. This is a contrast-enhanced T1 weighted image. Here's one facial nerve on one side, and there's the other facial nerve on the opposite side. Now, again, you have to ask yourself, as a radiologist, we'll say, well, that's kind of trivial, right? Say, the surgeons probably already know it's a malignancy because the facial nerve is gone, which is true. But what the surgeons don't know is whether or not the patients can be treated with a total parotidectomy, or is there retrograde perineural spread along the descending portion of the facial nerve extending into the skull base? Because if that's the case, then the surgeons will either have to partner with their neuro-otologist to drill the facial nerve out. But again, depending on your practice, if we, the radiologists, say that there's actually tumor growing all the way up along the facial nerve and extending up to here to the posterior genu, well, maybe these patients should be treated with chemotherapy and radiation therapy. So again, those are some of the advanced things that we can tell. So what we can do on imaging is that we can tell you whether there's a mass there. We can tell you whether it's involved in the superficial or the deep lobe. And we can also tell you whether the facial nerve's involved. And we also have the capability to map the proximal perineural spread along that nerve. And then you as a surgeons can take all of that information and then finally determine how you'd like to treat the patients. So the next space that we'll talk about is the parapharyngeal space. Now, the parapharyngeal space is basically next to the pharynx. So here's our pharynx here. This is our masticator space. So this is the masticator space here. This is the parotid space that's located here. This is our visceral space that's located here. The retropharyngeal space is going to be this potential space, and this is our pre-vertebral space. So this is a mass that's arising in the parapharyngeal space. Now, how do we know it's involving the parapharyngeal space? Well, look what it's doing to the masticator space. It's displacing the masticator space anteriorly. Look what it's doing to the carotid artery. It's displacing the carotid artery posteriorly. Look what it's doing to the pharyngeal wall. It's displacing the pharyngeal wall medially. And look what it's doing to the parotid gland. It's displacing it laterally. So this tells you the mass is arising from the parapharyngeal space. And the most common lesion to arise from the parapharyngeal space is going to be a minor salivary gland tumor, and the vast majority of these turn out to be pleomorphic adenomas. Now let's take a look at this case. This is the most common example of, this is an example of the most common process that involves the parapharyngeal space. So this arises and this involves. So normally the parapharyngeal space is a triangular space, but what we have here is a squamous cell carcinoma that's involving the junction of the tonsil and soft palate. Now, we all know now that this is HPV positive, probably HPV positive. So the question is, should this patient be treated with chemotherapy or radiation therapy? Should the patient be treated with surgery or non-surgery? So what are the things that we as radiology can provide? You can look at this and you can see this, but how do the deep spaces, the deep neck spaces come in to help you make your decision? Well, first of all, look at that parapharyngeal space. Instead of being nice and triangular, it's flattened. So this tumor is extending into the parapharyngeal space. Relatively close to the carotid artery. The carotid artery is not encased, but on the other hand, it's about 5 or 6 millimeters. And look what it's doing to the pterygoid muscle. Here's the medial pterygoid muscle here. Notice this acute angle between the superior constrictor muscle and the pterygoid muscle. Notice how this pterygoid muscle, this tumor is actually involving the medial pterygoid muscle. So it looks like there's actually, at the very least, abutment, if not invasion. And if you really have a good eye, you can see this anterior spread along the superior constrictor muscle. Now, none of this is necessarily a contraindication. Different surgeons have different comfort levels for performing tours. But on the other hand, from a radiologist standpoint, we need to do more than just say there's squamous cell carcinoma. Our job, as I mentioned earlier, is to define that deep type of spread. So the next space that we'll talk about is the post-styloid parapharyngeal space. Now, this space is also called the carotid space. It's called the carotid sheath, and it's called the post-styloid parapharyngeal space. The components, again, anatomy, are going to be the internal carotid artery, the internal jugular vein. There are various cranial nerves, 9 through 12, and there's also a little nerve right here, and you can see it right here. That's the sympathetic chain. So these are all the components of the carotid space. So one point of emphasis that I want to make from a purely nomenclature standpoint is that if you call this space the carotid space, then we should call this space the parapharyngeal space. If you call this space the post-styloid parapharyngeal space, then this space here needs to be called the pre-styloid parapharyngeal space. So just make sure you have a little bit of consistency. I would say in most cases right now, we will call this the carotid space, and then we'll call this the parapharyngeal space. But again, as I mentioned before, there are different terms for the same structures, and that makes things a little bit confusing. So again, I'll emphasize that anatomically based differential diagnosis. When we think of carotid space masses, we have to look at the internal carotid artery, the internal jugular vein, cranial nerves 9 through 12, the lymph node levels, and the sympathetic chain. So let's take a look at some differential diagnosis. Well, here's a contrast-enhanced CT demonstrating this big dilated vessel right here. And in fact, this is a carotid artery aneurysm. In this particular case, we can see the jugular vein, the carotid artery. In this case, we don't see the jugular vein. In fact, this is jugular vein thrombosis. And again, this is a carotid space mass. Here's an example of a carotid space mass. This patient presents with a left-sided Horner syndrome after trauma. So if you have a left-sided Horner syndrome, you have to worry about what? You have to worry about this dissection. So here's the internal carotid artery here, jugular vein. Here's the jugular vein, and there's the internal carotid artery. And look at the internal carotid artery right here. You see this eccentric area of increased T1 signal? This is all blood products in a dissected wall of the carotid artery. And this is the gradient echo sequence demonstrating the normal flow in the right carotid artery. And on the left, you just see a little smidgen right here of flow in the left carotid artery. And this smudginess outside of it is that blood products. So this is, again, an example of a carotid space mass. And in this case, the carotid space mass is a dissection. Now, the next couple of slides I think are really important to identify where these lesions are located. So this is an example of a mass involving the carotid space, but what I want to emphasize here is that there are no flow voids within this mass. Now, contrast this with this lesion. Here's a mass involving the carotid space, and if you look real closely, there are multiple flow voids within this. So this is an example of a schwannoma that can arise from typically the vagus nerve because there's no flow voids. But in this particular case, we see multiple flow voids, and this suggests the possibility of a glomus tumor. This is a CT angiogram demonstrating all these vessels. Notice the hypervascularity, and this is the conventional angio demonstrating the multiple flow voids in the glomus tumor. Now, one of the main things that I want to emphasize in this is I want you to draw a line down the middle and compare one side to the other side. So this is the masticator space here. This is the parotid space here. This is the parapharyngeal space here. And this is the carotid space here. Notice the carotid artery. Here's the internal carotid artery. If the carotid artery was displaced posteriorly, then the mass would be in the parapharyngeal space. This is what we just showed earlier. But notice how the carotid artery is displaced anteriorly. When you have this anterior displacement of the carotid artery, that tells you that the mass is arising in the carotid space. So if you see this mass here involving the carotid space and you see multiple flow voids, that's how you can make the diagnosis of a glomus tumor. So look for how that carotid artery, it's a really, really good indicator for me to properly identify the space of that mass. So there you go right there. Then the last two spaces that we'll talk about are the sublingual space and the submandibular space. So the sublingual space is pure and simply the space that's located below the tongue. And again, this is where we get a little bit confused, again, by different terms. So sublingual is lingua, meaning tongue in Latin. But on the other hand, glossus is Greek for tongue. So when we talk about the spaces of the tongue, when we talk about the spaces, sublingual, we use the Latin root. But on the other hand, when we start talking about the muscle, so for instance, when we talk about the genioglossus muscle, we're using the Greek root. When we talk about the muscle that goes from the hyoid bone to the tongue, that's the hyoglossus muscle. So we use the Greek root. And again, that's where it gets a little bit confusing. So let's talk about the anatomy of the sublingual space. Well, the lateral margin of the sublingual space is formed by the mandible. And this little line right here is the myeloid line. So the muscle that goes from the myeloid line all the way to the hyoid bone is going to be the mylohyoid muscle. Just medial to the mylohyoid muscle is the sublingual gland. Just medial to this is going to be Wharton's duct. Just inferior to this is the lingual nerve. We're going to have the lingual vein, and then you're going to have cranial nerve 12. There's our hypoglossal nerve. So this is this little wedge-shaped area between the mylohyoid muscle and this muscle, which is the hyoglossus muscle. And as you know, just medial to the hyoglossus muscle is going to be the lingual artery. So there's our lingual artery here. So when I look at this and then I look at both sides, I see the mandible, I see the mylohyoid muscle, I see the hyoid bone, I see the hyoglossus. So the way I think about it is I sort of think of this as a teacup. So the sublingual space to me is everything within this teacup. So what forms the teacup? Well, the rim is formed by the mandible. The wall of the teacup is formed by the mylohyoid muscle, and the base of the teacup is formed by the hyoid bone. So all of these structures, the genioglossus, geniohyoid muscle, the lingual artery, the hyoglossus muscle, Wharton's duct, cranial nerves, the lingual nerve, the hypoglossal nerve, so on and so forth, are all located within the teacup. So now what are some pathology to involve the sublingual space? Well, this is the most common pathology. It is squamous cell carcinoma. So this is a contrast-enhanced T1 weighted image demonstrating the squamous cell carcinoma involving the floor of the mouth. Now, I want to point out this muscle right here. This muscle that goes from the genial tubercle back to the tongue base is the genioglossus muscle. And one of the questions I often get is, how do I know when the floor of mouth ends? Floor of mouth is the same as a sublingual space, and the tongue base begins. And it's as follows. Notice how these genioglossus, geniohyoid muscles are vertically oriented. And look at the tongue-based musculature. Notice how these tongue-based muscles are transverse. They go from right to left as opposed to top to bottom. So this junction right here is where the muscles end, the genioglossus muscles ends, and this is the junction of the floor of the mouth with the tongue base. So that's sometimes it can be a little bit challenging. It is important though if you're trying to determine whether to do HPV testing, because as you know, floor mouth lesions are most likely going to be HPV negative, and tongue-based lesions, and because they're part of the oral pharynx, are going to be HPV positive. So when you are in your tumor boards, those are things that you should always consider. So here's an example of a patient that presents with a floor of mouth infection. Here we can see this large mass right here. We can see there's fluid, we can see air, and this is the typical appearance of a sublingual space abscess. Now, it's always important to reconstruct these in bone algorithms, because when you look at the bone algorithms, we can see this little periapical fluid collection, and this abscess was due to this rotten tooth. Now, you guys all know this, but from a radiology standpoint, again, please make sure that you're reconstructing these in bone algorithms. And this is an example of a cystic lesion involving the anterior floor of the mouth. This is an epidermoid. If it was more posteriorly, it would be a thyroglossal duct cyst. And this is an example of a cystic lesion involving the floor of the mouth. Look at the anatomy: genioglossus muscle, sublingual gland, mylohyoid muscle is here, and this is extending from the sublingual gland posteriorly, and this is an example of a ranula. And then the last space we'll end with, we've got started a little bit late, so I'll just take liberty and do 2 more minutes, and that's the space that's below the mandible, and that's the submandibular space. So again, we're all experts here. Here's the mylohyoid muscle, and just deep to this is the submandibular space with the submandibular gland. So the most common, the most frequent component, or the largest component of the submandibular space, are actually our lymph nodes. So I don't know if we've had a talk on lymph nodes yet. I'm sure we'll schedule that upcoming. But the level 1 lymph nodes are the most common pathology to involve the submandibular space. And these are all metastatic lymph nodes to involve the submandibular space. Then the next thing that we want to do, and I'm sure you'll see this, if you go into a community-based practice, you'll have a lot of patients that are going to present with neck masses, especially in the submandibular space. And it can be hard to differentiate whether or not you're dealing with a mass involving the submandibular space or you're dealing with something that involves the lymph nodes. When we look at this submandibular gland, we can see that it's enlarged and it's enhancing. And if you look real closely, we can see dilatation right here. And this little dilatation extends anteriorly and stops at this little stone right here. So this is a little cyalolith involving the floor of the mouth, but these patients present with a submandibular space mass because this is resulting in sialolithiasis and obstructive sialadenitis involving the left submandibular gland. So it's always important to understand that anatomy when you're looking at the submandibular space. And then the last thing that I'll talk about too is that here's another example of an enlarged submandibular gland. So in this case, I showed this enlarged submandibular gland due to a little stone. But anytime that you have an older patient and they present with an obstructive sialadenitis, it's really important to look in the floor of the mouth. So what I like to do is I draw a line from one side compared to the other side. And I don't know if you guys have rotated with me down in Indianapolis, but they always joke every week because I always talk about my tiger stripes. And what I mean by tiger stripes is that when you look at the head and neck, there are actually lots of stripes that you can see. So for instance, here's a white stripe here for the bone. Then you can see a little black stripe right here, which is the fat. You can see the white stripes right here, which is the vessels. You can see a black stripe right here, which is part of the sublingual space. And then you see a gray stripe right here, which is the genioglossus muscle. So these are the normal tiger stripes on the right side. Now look at the left side. Here's our mandible right here. There's the white stripe, but notice how the black stripe is gone. And look what happened to these vessels. These vessels are displaced anteriorly. So when you sort of step back and you look, you're like, wow, I see a lot of stripes here and I see a lot of normal fat, but on the left-hand side, I see a soft tissue mass. When in fact, this was squamous cell carcinoma involving the floor of the mouth. It was involving Morton's duct. And that's why this patient presented with an enlarged left submandibular gland. So again, when you see that submandibular gland, yeah, it's important to look for tumors involving the gland. It's important to look for stones, but you never want to miss that occult squamous cell carcinoma. So in summary, what I've done over the last 50 minutes or so is that we talked about the spaces of the head and neck. So remember, masticator space is muscles of mastication. Visceral space for my radiology friends is when you open your mouth, everything you see is in the visceral space. The retropharyngeal space is that space behind the pharynx. The prevertebral space is going to be the spine and the discs. And remember our friend, the chordomas. The parotid gland, we talked about the facial nerve and how we separate superficial lobe from deep lobe. The parapharyngeal space was next to the pharynx. We talked about the carotid space, which is the carotid artery, jugular vein, cranial nerves 9 through 12, the sympathetic chain, and the lymph nodes. We talked about the space below the tongue, which was the sublingual space. And then finally, we talked about the space below the mandible. So thank you very much for your attention. I apologize for getting the dates confused, but hopefully this turned out okay. So also happy to answer any questions.